Hello and welcome to another podcast from Western University's Critical Care program. Today we're going to be discussing a key topic called septic shock. This discussion of sepsis is not meant to be an all-encompassing review of the topic or a deep dive into sepsis, its pathophysiology, and sepsis care. The care of a patient with septic shock has evolved over the years, and in fact, due to all the complexities that were first initiated, it has now come down to some very basic things, and we will discuss them. Sepsis and septic shock are a very common presentation in the ICU. They account for approximately 10% of all ICU admissions, and mortality can be up to actually 30 to 40%. It used to be much greater a few years ago. Many admissions to the intensive care unit occur because of septic shock, and in fact many patients in the world die from this condition. Before we talk further, let's talk about some key definitions. These are things that attendings are usually very favorable in asking junior staff. The first is SIRS, or the Systemic Inflammatory Response Syndrome, and this is defined as really four things: a white count, sometimes it could actually be the absence of a white count, the presence of a fever or hypothermia, elevated heart rate, and elevated respiratory rate. Once this is asked of you, usually the next thing that comes about is that essentially 80 to 90% of patients in hospital exhibit some element of SIRS, and in fact most people in hospital have some form of an abnormal inflammatory state. So this alone is not what sepsis or septic shock is all about. What sepsis is SIRS with a source, either a known source or a suspected source that is a pathogen, usually a bacterial pathogen. Severe sepsis is the concept of sepsis itself, however, with end organ dysfunction. End organ dysfunction can be defined as low urine output, abnormal mental status, the presence of lactate, or impact on other systems, for example, elevated creatinine, coagulopathy, these sort of things. Septic shock is a severe sepsis that is refractory to adequate volume resuscitation. And what exactly is adequate volume resuscitation? That is approximately 20 to 30 cc's of fluid per kilogram of mass. And of course, the dependency on vasopressors. So therefore, as you can appreciate, just like other definitions of shock, the word hypotension or low blood pressure is actually not anywhere to be found. In fact, what it all has to do with is tissue perfusion, and septic shock is an abnormal state of tissue perfusion, a form of shock known as distributive shock, where there's abnormal vasodilatation and tissue leakiness of the vasculature, allowing more and more fluid to accumulate in spaces that fluid should really not be in a normal physiologic state. The overall process, however, of septic shock is much more than that and involves multiple systems, as we'll discuss briefly. The pathophysiology of all infectious disease, and certainly in the setting of septic shock, is always the same. The disease process that we witness as clinicians is really the product of both the infectious agent and the host response. And that relation and contribution may not necessarily be linear, additive, or multiplicative. It could really be a nonlinear relation. But what it really is that it's not just about the infectious agent, it's also the host response. And sometimes the host response, the inflammatory cascade, and the consequences of that cascade or what get the host in trouble. The manifestation of both of those things is what the disease is actually all about. This is a more complicated slide of the actual inflammatory response and the cascade, and as you can see here, the pathogen causes a release of cytokines, and not only is this innately due to the host's immune response, but also the host factors such as age, genetics, and other medical illnesses that may be present. And now this inflammatory cascade not only activates the leukocytes but also complements and also the coagulation cascade as well. In addition, apoptosis can occur due to impaired immune function, and there is dysregulation of both endocrine and neuroendocrine pathways. In addition, there is alteration of actual gene transcription, which can be pro-inflammatory. At the tissue level, the reason for shock, there is really the central concept of endothelial dysfunction. And this endothelial dysfunction occurs, again, not only due to the activated immune system, but also the abnormalities within that system once activated at this level. So there is vasodilatation resulting in low blood pressure, red cell deformability changes, the actual endothelium changes, a structure is lost now known as the glycocalyx, which is a proteinaceous layer that surrounds the base layer of the endothelium, and this is what causes the leakiness. We used to think that patients who were sick at just a low albumin state, as you know, albumin is an acute phase reactant and negative phase reactant, decreasing acutely in illness, and that this loss of oncotic pressure resulted in a fluid to extravasate. However, it's not like that. It's actually more complicated, and there is actually a loss of coupling at the vasculature between cells, and loss of cells, in fact, that actually make up the endothelium. All of this goes to cause tissue hyperperfusion and tissue dysoxia, if you will, and this ultimately results in loss of perfusion to vital organs. And in fact, at the level of the mitochondria, they may also undergo abnormal pathophysiologic changes resulting in dysfunction, so-called shunting, where energy or oxygen is delivered to the tissue, but the mitochondria cannot use it, and therefore it's shunted away. So what else do we know? We know that in the clinical setting of sepsis, blood cultures are typically only positive in approximately 1/3 of cases. We also know that 1/3 of cultures is never positive, in fact, from any source. When it comes to the organisms, we're going to focus on the bacteria. They are the gram-positives, and in fact, most commonly Staph aureus, both MSSA or MRSA, and strep pneumo. On the gram-negative side of things, E. coli, Klebsiella, and of course Pseudomonas are the most culprit agents. Other things that contribute to the host response and also maladaptive response of the host are risk factors, and that's really immune compromise, presence of the infection itself, but also non-infectious things such as the presence of cancer, chronic kidney disease, diabetes, any chronic illness, and certainly patients that have devices, for example, long-term catheters such as dialysis catheters. These are again pathways and portals of entry. And of course, there are most likely genetic factors that also predispose patients to the most severe form of sepsis, septic shock, which is not purely dependent on the organism again, but more also with the interaction of that organism and the host response. Out of all of these things with regards to our current understanding of sepsis care, which really started with a paper by Emmanuel Rivers in the New England Journal called Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock, these things have all evolved into what we now know as the Surviving Sepsis Guidelines. The paper by Emmanuel Rivers came out in 2001, formulating some good discussion in the literature, and this resulted in the culmination of the first guideline in 2004, with the most recent iteration being 2012. What that initial paper showed us was that early attention to patients in septic shock was important, and that could make a huge difference in their mortality. What was not known, and was one of the biggest criticism of that paper, was that many things were done at the same time. For example, patients got central venous catheters, patients got blood transfusions, patients were put on vasopressors, patients got early antibiotics, and we never knew really what was the key thing there. As time evolved and the sepsis guidelines and our understanding of sepsis also evolved, we understood that most likely giving fluids early, starting vasopressors early, and delivering antibiotics early, and in fact broad spectrum antibiotics, is what matters most. However, we didn't still know if we needed to do very aggressive care, and in fact it turns out that some of the more numeric based titrated approach, such as making sure that everyone has a central line, making sure that every central line is now measured, for example, venous saturations, it turns out that some of the more complex, nuanced aspects of sepsis care as initiated in that initial 2001 paper are probably not necessary, and that it's really the ABCs of sepsis care, fluids, antibiotics, pressors, that are important in the early first few hours, and those are what make the biggest difference. With that, let's talk about not only what the current guideline says, but a very practical approach to the topic. If there's one guideline you're going to attempt to read during your ICU rotation, we do recommend that you have a look at the Surviving Sepsis Campaign guideline from 2012. It has many summary points and very good tables that you could look at. The entire guideline, of course, is also very readable, but it certainly is well put together, and there is some good Canadian contribution as well as some key international figures in critical care as well. The key thing really is the development of sepsis bundles, and these are really a package of interventions that are instituted in the initial care of the patient. And so the crux of it is really that within the first 3 hours, patients that are thought to have sepsis and septic shock should have lactate drawn. And usually a lactate greater than 4 is an alarming number, because if it's elevated, it usually means that there is something sinister going on. In the setting of septic shock or severe sepsis, this is a marker of tissue hypoperfusion. Early blood cultures will be helpful. Again, why not change initial management? And as we talked about earlier, some large proportion of blood cultures, in fact, can be negative. However, it is important, if you can, to draw blood cultures. The next thing is to go ahead and administer broad spectrum antibiotics. And that is really key. For every hour that has gone by without antibiotics, the mortality for sepsis and severe sepsis and septic shock, in fact, does increase. And fluids, early administration of crystalloids. In fact, we recommend more of a balanced salt solution like Ringer's over normal saline at approximately 30 cc's per kilogram is also a key target established within the first few hours of identifying that patient with a severe sepsis or septic shock. Looking at the guideline itself, it does talk about that initial crystalloid resuscitation. It talks about the 30 cc's per kilogram as a marker of adequate resuscitation. And at this point, it's important to note that you really should try not to flood your patients, especially those that are in distributive shock, because we know that that fluid extravasates. We know that a large proportion of that fluid just ends up in tissues, increasing the interstitial pressure, and ultimately patients that are severely fluid overloaded not only can get into metabolic abnormalities. For example, if they're resuscitated with large volumes of normal saline or so-called normal saline, a solution that has a pH of 5.5 with 150 roughly equivalents of sodium and chloride, this solution causes actually a metabolic acidosis in the form of hyperchloremia. We know that more balanced solutions such as Ringer's lactate are actually better. All that said, large amounts of crystalloids ultimately don't help the patient. They most likely cause or contribute to the possibility or evolution into ARDS, acute respiratory distress syndrome, in patients with septic shock. And so what really needs to happen is you know the etiology of this shock. You know that it's endothelial dysfunction, leakiness of the blood vessels, and so vasopressors should really come in early in this type of shock. Talking about some of the more protocolized care that has now been somewhat debunked with the most recent trial, this really still has not made it into the guidelines, and the guidelines are going to be revised once 2 other international studies come out. But the 2012 guidelines suggest that patients with severe sepsis and septic shock do get a central venous catheter, and that central venous catheter can be used to provide a few numbers, one of them being the central venous pressure, sort of 8 millimeters of mercury for a patient that's spontaneously breathing, and higher for patients that are intubated. And so this is a marker of the venous pressure. It's a pressure at the right atrium and the amount of venous blood returning to the heart. And so the idea is that you want to make sure that the tank is full, that the person is well fluid resuscitated before you start squeezing them with vasopressors. And so there's this notion that central venous pressure should be at least 8 in the non-ventilated patient and 12, a little bit higher, accounting for the presence of positive pressure ventilation. The truth of the matter is that CVP, or central venous pressure, has no direct correlation to intravascular volume, and that this is just a marker like anything else. It can't be used as a sole agent. With that said, if your patient has a negative CVP and you've given 2 liters of fluid, you know what, they perhaps need more. And now with the advent and routine use of point-of-care ultrasound, in fact, we can do a much better job at assessing the patient's volume status. All in all, once the patient has been identified to have severe sepsis or septic shock, go ahead and give 2 to 4 liters of crystalloid, start some element of maintenance, but don't flood the patient and start vasopressors. Targeting a MAP of 65 millimeters of mercury is common sense. A recent trial showing that there was no difference targeting a higher MAP. Your only consideration here is that if you know your patient is clearly hypertensive chronically and runs around at a MAP of 85, and now it's coming in with a systolic blood pressure of 90, well, a MAP of 65 in that patient may not be sufficient, and in fact you may need to target a higher MAP. But certainly targeting MAP of 65 as the organ perfusion pressure is really a reasonable goal, and that is what is recommended by the guideline. As mentioned earlier, in the first 3 hours, you want to try to get some normalization of that urine output. These patients are typically intravascularly dry and usually are oliguric or anuric when they come in. Therefore, urine output greater than 0.5 cc's per kilogram per hour is what is required to sort of be adequate output. Another marker that can again be measured in the first 6 hours is something called the central venous sat. This is really a blood gas, a venous blood gas in this case, from the most distal port of the central line, and the saturation on this gas is what is looked at, and it should be 70%. Approximately. If it's 40%, that suggests that there is something you can do about tissue delivery of oxygen, and that the tissues are hyper extracting oxygen, and so maybe more forward flow with an inotrope such as dobutamine is needed. Or let's say the patient's hemoglobin is 60, then you can give them that 1 unit of blood and reassess. That may be something that will improve tissue oxygenation. That may not be fixable by just giving fluids and vasopressors. So what is interesting though is that the most recent trial, as I mentioned, called PROCESS, which is a randomized controlled trial comparing early goal-directed therapy as it was envisioned in 2001 from the Rivers protocol, comparing that to usual care in the center and then a bit more of a protocolized care, there was no difference. And so the suggestion is that if you start being very vigorous in tracking things like central venous saturations, this may not necessarily be the thing that's going to turn your patient around. Just for educational purposes, a number is also mentioned here as 65% as the mixed venous. That really comes from a pulmonary artery catheter or a Swan-Ganz catheter. That is, again, is a venous gas from the distal port, and it's a venous saturation, but we're not using these catheters frequently, and so for all intents and purposes, mixed venous saturation is something you're not going to see anymore in most critical care centers, including ours. Most folks do say that if a patient comes in with an elevated lactate, that by 6 hours you do want to see that lactate going down. And in fact, if that second or third measurement is on its way down to normalization, coming below 4, approaching a lactate of 2 millimoles per liter, then you know that you're doing a good job adequately resuscitating that patient, and most likely you don't need to keep trending that number. By the same token, if that lactate rebounds, mortality can be as high as 40%. As mentioned earlier, blood cultures are important, at least 2 sets, each set being an anaerobic and aerobic bottle, and so 2 sets of blood cultures is 4 bottles of blood, in case there's any confusion around that. This is now the summary of the Surviving Sepsis bundle, this compilation of intervention. In the first 3 hours, fluids, antibiotics, vasopressors, blood cultures. In the next 6 hours, essentially tracking some improvement in that end organ perfusion, whether that is the reduction in lactate, well, volume resuscitated, producing urine, and then there are these other adjuncts that you could use as numerics to track your resuscitation, such as the central venous oxygenation, and in the cases where there's a Swan-Ganz catheter, a mixed venous. An important point about antibiotics: when you have a patient in severe sepsis or septic shock, go ahead and give them a dose of a broad spectrum antibiotic. This is not the time to be a steward for antibiotic therapy. We know that early therapy has a mortality benefit. We know that you need to go broad in considering the patient's allergies. You may have to pick a different medication than peptazo. Even carbapenems may or may not be the right choice. In fact, if you have a patient that's complicated, then certainly consulting infectious disease would be important. But certainly any broad spectrum antibiotics, so that's peptazo, ceftriaxone, or ceftriaxone and vancomycin can be used. Again, depending on what you think is going on. Typically, for your normal ICU patient that does not have an anaphylactic allergic response, peptazo is a good choice. Also, in the patient with severe sepsis or septic shock who you may be expecting has an element of meningitis, don't forget that the antibiotic coverage and dosing is different in that case. Certainly, patients can be bacteremic, presenting in septic shock, and also have meningitis. In that case, what you're looking for is ceftriaxone, vancomycin, and ampicillin, plus or minus acyclovir when covering for possible viral herpes encephalitis, although these patients are rarely in systemic septic shock. There is a note here about double covering Pseudomonas in certain patient populations. These days we don't typically cover Pseudomonas in a double manner. However, in patients that are known to have some element of multi-drug resistant Pseudomonas, then these patients typically do get some double coverage. This is a slide just demonstrating the importance of antibiotic therapy, and so you can see that for every hour after 6 hours there is approximately a 7.6 decrease in survival. Another important point, aside from giving that broad spectrum antibiotic, is to make sure that you don't be very focused, because that actually causes detriment to the patient. If you give a very narrow coverage right off the bat, you can actually harm patients. Another important point is that patients with renal failure, you don't need to worry about that first dose. That first dose can be the full dose, a dose that you're most familiar with. Now a word about the actual vasopressors. The choice vasopressor in septic shock, and in fact it turns out in most kinds of shock, is norepinephrine or Levophed. This medication is safe to be given through a central venous line, and in fact if you have a very good peripheral IV that you have inserted yourself, for example on the floor, and a patient that you're bringing down, you can start some norepinephrine peripherally. Just be cautious that if it extravasates in a severe manner, it can cause tissue necrosis. The focus really, though, is on norepinephrine as the first choice. This medication has both predominantly alpha effect, and also some beta 1 effect. It really has no beta 2 effect. The concept here is that you should have enough volume resuscitation with that initial resuscitative phase to then add on a vasopressor. The next drug to add on, if still pressures are not adequate, for example you're trying to achieve a MAP of 65 and you can't achieve that MAP, really should be vasopressin. It's well understood that vasopressin works synergistically with norepinephrine, and actually together they cause a good effect. Now vasopressin at the doses we use is at essentially 2.4 units an hour, and that dose is really what is believed to be a physiologic replacement of vasopressin, or ADH. This is known to be a depleted state, a septic shock that is, and this replacement helps the body and the endothelium squeeze appropriately to counteract the abnormal vasodilatory response that is occurring. According to the guideline, if on top of that you still need to have pressure and you're not able to achieve your target, then epinephrine can be used. Just note that if you run an epinephrine infusion, that the lactate can no longer be used as a marker of improvement, because epinephrine as an infusion increases the plasma lactate, usually for about 24 hours, and then it goes away by itself. It is not a marker of worsening tissue perfusion, and that's important to understand. A drug like dopamine should not be used. It has really no benefit, causes a lot of tachycardia and ventricular ectopy, and really has no role. And you may have heard in the past about something called renal dose dopamine. This again is not really a factual effect, and improvements that you see in renal outputs, for example urine output, do not really translate to renal protection or improved renal perfusion. Lastly, a word about steroids. We used to give patients steroids in septic shock right off the bat. These studies ultimately were not replicated, and the strategy was probably flawed, because what happens in sepsis is that both albumin and cortisol binding globulin levels decrease. Therefore, the free or biologically available cortisol endogenous levels are actually normal. But what we were measuring were total cortisol levels, and noticing that they were depleted. And we're then doing ACTH testing on patients and giving them supplementary steroids, and noticing that it didn't make a difference. And the reason was that these patients probably did not have an element of adrenal insufficiency, given that the normal levels were actually okay at the free form, but the total levels were depleted, but we weren't accounting for those changes, as I said, in cortisol binding globulin and albumin. What is important, though, if a patient does not have adequate blood pressure, despite 2 or 3 vasopressors, certainly the 3 vasopressor mark, then giving that patient hydrocortisone 100 milligrams Q8H is reasonable and in fact recommended. Lastly, a word about blood pressure. Patients who are severely acidotic with bicarb levels less than 12 or have hypocalcemia, these patients will not really respond to vasopressors until you fix those things, the acidosis and the hypocalcemia. Again, being different entities that can be both present together or separate in different patients, depending on their medical background and underlying causes. In the setting of acidosis, septic shock is usually a lactic acidosis state, and so giving bicarbonate is not recommended, because you need to actually just fix the underlying tissue perfusion. You don't need to give bicarbonate therapy. However, if the serum bicarbonate as measured in the electrolytes is below 12, it is going to be very hard to get the systems, for example endothelial systems, coagulation systems, to actually work. and so probably a couple of amps of bicarb is not unreasonable. Just remember that bicarb dissociates to water and carbon dioxide, and if you're not venting that carbon dioxide appropriately, then worsening intracellular acidosis occurs. In addition, hypocalcemia is a problem for the vasculature, and so giving calcium is important as well, to making sure the calcium levels on your ionized calcium and the ABG are all normal. If they are not normal, replacing those levels is important. This is the PROCESS trial that I mentioned earlier in this podcast, and this is a randomized controlled trial in tertiary centers where patients were given either the early goal-directed therapy as per the 2001 protocol from the Manual River study, as opposed to usual care, as opposed to protocolized care. This really is the, if you will, DEF of sepsis care, not the ABCs of sepsis care, and that not surprisingly, these things such as following central venous sats or making sure that patients get catheters, central line catheters, and following these targets in a regimented manner, or automatically blood transfusing patients if their central venous sats were less than 70%, none of these more aggressive or nuanced interventions really had any difference in outcome. In fact, they did not change any meaningful parameter. And so what's important really is, as we mentioned before, is this business of making sure patients are adequately volume resuscitated, that they're not flooded with fluids, pressors come on early, antibiotics come on early. Source control, again, is very important. So if there's a line infection, pull out that line. If there's an abscess, drain that abscess. Those are the kind of the key things that need to happen in the care of your patient. So this is a recap of everything we just talked about. Just don't forget that you have to get some element of markers as well. It's not a bad idea to get all of these patients to have a plasma lactate level and to trend that. And the other thing is to consider these adjuncts. Point of care ultrasound will help you understand if the lungs are full of fluid already, or if there's an ARDS pattern already going on potentially. Certainly looking at the heart, looking at the IVC will help you try to understand something about the patient's volume status. Most patients can easily tolerate 2 liters of fluid right off the bat as your consultant on these patients in the setting of sepsis, but certainly after that, sort of beyond the 4-liter mark, you really want to have some understanding of what's that patient's intravascular volume before you indiscriminately go ahead and give it. Certainly optimizing the cardiac status. In some patients, they might have concomitant sepsis-induced cardiomyopathy. So if you measure that central venous saturation and their hemoglobin is normal, and you're giving them a blood pressure and the central venous saturations are 40% or 50%, suggesting again hyperextraction of oxygen, you may consider a drug like dobutamine to increase the inotropy of the heart. However, this usually is always done with a setting of levofed being present, because the beta-2 effect of dobutamine will likely drop the pressure of that patient. Thank you for joining us for this podcast on the care of the patient in severe sepsis and septic shock, and some of the really basic management strategies that need to be at the forefront of your thought processes when you see these patients. We look forward to having you as an audience in the next podcast. Bye for now.